Good evening, everybody. On this day of International Women's Day, we have started our webinar today on bone health. I would like to request Dr. Aarti ma'am to start the process.
Welcome, everyone. Thank you so much for joining us today. And we are excited to have you here. There will be an opportunity for us to learn from each other and grow together. Let's take a moment to introduce. I was waiting for Dr. Anup is there from IO Official. So, Dr. Anup, can you have, or we should wait for Dr. Ram Chaddha, Dr. Naveen, sir? What do you suggest, sir?
As you might decide, I think you're running out the time. You
Yes,
should
sir.
keep going.
So I would request Dr. Anup to please address and start this webinar.
Thank you, Aarti, for keeping me here. What a day to start Holi and International Women Day. Every day we are discussing at every forum the diversity and inclusiveness. I'm surprised that why do we need to now celebrate actually an International Women's Day? I'm seeing the time to come when we would be celebrating International Men's Day, the way you guys are progressing. So happy Women's Day and happy Holi to you all. It's wonderful to see that WOICE committee is heading for an academic webinar. This is first in the series. All the best to all of you and many more to come. Congratulations for this wonderful webinar. Happy to see you again. Thank you.
Thank you, sir.
You can go ahead, Aarti, now.
Yes.
Aarti ma'am, would you please like to give a voice of welcome note?
Yeah. Thank you, Ritwika. Our world would mean nothing without a woman. Always stand for a woman because they deserve it. Empowering a woman is like empowering a humanity. Little girls with a dream, they become women with a vision. Woman health is her capital, and her body hears everything her mind says. Being healthy is not just about getting on a scale and measuring our waistline. We need to start focusing on what matters and how we feel about ourselves. Every movement in our body is a complex act of musculoskeletal system, as we all know. So bones, they play important role in maintaining our system of the body. System-based approach that is required for the bone health, and that is only through education. So to educate our patients about prevention, assessment, diagnosis, and treatment of bone that is required. So I request Dr. Ritwika to please start the video of voice and then we can proceed with the webinar.
Thank you, ma'am.
In the beginning, there was man, and for a time, it was good. लड़ने चली आजादी की जंग लेकर सूरज से
लगता हमको मगर कुछ कर देंगे हम मगर ख्वाब में जो दिखा पर था छिपा बस जाएगा बादल पे पाँव है या झूठा पाँव है अब तो भी चल पड़ी अपनी नाव है बादल पे पाँव है या झूठा पाँव है अब तो भी चल पड़ी अपनी नाव है
Yes, ma'am, that was a very inspiring video for all of us.
Thank you, Dr. Ritwika.
If I have the permission of my esteemed seniors, can I introduce the panelists for today's evening?
Of course.
We have Dr. Rushma. She's one of our founders and an eminent member of AO Spine. We have Dr. Meenakshi, head of the department and professor in the Department of Geriatric Medicine in AIIMS, Rishikesh. And we have Dr. Chasanal Rathod, an APOA Waves member and a BOS Executive Committee member. I would like to request Neha ma'am to start the presentations.
Thank you,
Over to
Ritwika.
Neha.
Yeah, thank you, Ritwika. We have lots of stalwarts today in this meeting. So actually, I'm overwhelmed to see all the panelists and speakers, not only from orthopedics, but out of the orthopedics. And they have collectively come together for improving the women's health. So without much ado, I would like to start with our first presentation. And I would like to invite our senior most orthopedic surgeon, Dr. Shobha Arora Madam, who's a professor and head of orthopedics at AIIMS Rishikesh. And she is a president of North Zone Orthopedic Association. Shobha ma'am will be talking on immune system and bone interplay. So over to you, Shobha ma'am.
Thank you. I retired 2 years back, so currently I'm not heading the department, but yes, definitely I am president North Zone. Thank you for the introduction. Can I share the screen?
Yes, ma'am.
Is my screen visible to all?
Yes,
Yes,
ma'am.
ma'am.
Am I audible?
Yes, ma'am.
Right. Good evening, everybody. Happy Holi and happy Women's Day. We have been working in orthopedics, which is more of a macroscopic kind of specialty by notions. But I believe that at the microscopic and the molecular level, there is much more to learn. And unless you get the lab to the patient, probably the knowledge and treatment both will be incomplete. So I have chosen a subject which is usually not popular because it takes a little more peeping into the microscope. So let's see what the immune system has and the bone has in between in the interplay. We must know the why of osteoporosis. As a scientific person, as scientists, we are curious about why this happens. That's the basis of science from Newton to everybody. So do we blame aging? Oh, it's just people get old and women get old, so they get osteoporosis. And then it is painful. So just go ahead with it, accept the pain of aging, take some medicine or do whatever you think is good for you, reduce your activity. But it does reflect on how my whole life was. What did I do for my whole life as activity? So is this a sequelae or a boon of my lifestyle? That will tell us the immunology of our bone. Okay. The answer to these questions is both yes and no, because your lifetime physical activity decides your peak bone mass. Your lifestyle now decides how much bone loss is happening. What were you eating then and what are you eating now? Your diet, the balanced diet. What were your habits then? Were you having a floor level activity routine? That's one of the biggest things I believe, and I have come to believe it with experience, that unless you use all your joints to the fullest extent of their range of movement, definitely the activity is not complete. And squatting, sitting cross-legged, kneeling are one of the important parts of activity which probably are not included in the current Western dominated lifestyle. I call it a 90-degree culture of knee flexion and hip flexion, but definitely floor level activity is something that matters. What were my habits then? I was a drinker or I was a smoker, depending upon what was my cultural background and some natural factors which I inherit in my DNAs. Pictures of osteoporosis have been plenty on the net, but I would like to draw your attention to a small thing. It's the per unit bone mass that makes the difference. And this per unit bone mass has a compressive strength. Bone is supposed to be loaded cyclically. Cyclical loading is the key to which the bone must withstand. And the per unit bone mass decrease definitely causes a break in the cyclical loading. Looking at the composition of the bone quickly, we have all gone through that. There's a protein matrix and a mineral component. Different proportions of different minerals have been quoted. All said and done, what happens if there is a change in the standard bone composition? We know if the mineral component is lost, which is most commonly seen in children and at times in adults also, you get soft bones, the rickets and osteomyelitic bones, which bend easily under cyclical loading. If you lose the protein matrix, you get brittle bones, which break like chalk. And if you lose both protein matrix as well as the mineral, you get the fragile bones. So you have the soft bones that bend, the fragile bones that break, and brittle bones that break and fragile bone that crumple. So talking at the cellular level of osteoporosis, it has been found by Indian scientists. I found some good paper from our own Madhya Pradesh Institute. Some of the biomedical and biotechnical people have published papers, not the orthopedic surgeons, that T cells and T cell induced cytokines are the substances that regulate the bone turnover. Now, T cells have their origin something to do with the thymus related cells, and thymus, of course, is not in adults. So this is decided right at the childhood that your T cells, how are they going to behave towards your bone? Any dysregulation of these cells by any reason, be it from genetic reason or be it by an acquired reason, will cause an immune dysregulation. Now, this is a new term. Nobody thinks of immunology in osteoporosis, but this is a new term. And as I said, these are papers about the T cells that are from AIIMS New Delhi and other institutes, which are non-medical institutes also, and they coined a word, immunoporosis. Now, this is immunology of osteoporosis with the role of T cells in it. So this is immunoporosis, as well as this is a paper from China, and it says that there's a specialty now which is called osteoimmunology, the immune imbalance inside the cell of cells that go for bone loss as well as for bone formation. They are centered around T cells, and there's much more molecular genetics to it, but we'll just stick to T cells. So how does it translate into patient therapy? That T cell targeted therapy will improve the osteoimmunity, and PTH therapy, which is given currently, is one which targets the T cell function. Like stem cell, people have tried at experimental level whether you should have a direct T cell therapy, but that's still not into clinical practice. Standardization has not yet been done. We know the changes at menopause, decreased calcium absorption, renal function, and vitamin D metabolism. But at the cellular level, the adaptive immune system plays a fundamental role in the development of postmenopausal osteoporosis. Therapeutic indications of immunomodulations have not yet been formulated. If you say there is a change in the adaptive system, the next question is, why don't you immunomodulate? No, this is not that kind of immunomodulation which you do in autoimmune diseases or something. So this is still under very much a research topic. And to us, I bring you back again to the same level. Exercise is the simplest therapy, not at the onset of osteoporosis, but to prevent the osteoporosis. Long time ago, when osteoporosis was just coming on the stage, I had an opportunity to study for something and a huge literature material that time, that must be somewhere around 15 years back, maybe 20. It showed that everything else may or may not work, but the one thing that works sure shot is exercise at any age, And now it is proven that the exercise improves the osteoimmunity and the T cell regulatory function automatically. So why do you need a T cell targeted therapy drug? This is one of the most amazing thing, that simplest thing. A woman is active. They say there is nothing like a non-working mother. Mothers are always working. So if you are always working, then you don't need an extra physiotherapy or something. And mind you, I repeat, a floor level routine activity, which was part of our culture earlier, is now becoming uncommon, but consciously floor level activity is most important because it gives it takes the strongest muscle to get up from a floor level position. And whatever is the reason, one must do this activity to keep the bone strong, and the bone immunity, cell regulatory function improves with that. Regular physical exercise, these are excerpts from one of the newest papers. Most powerful non-pharmaceutical strategy of treating osteoporosis is exercise. So to conclude, immunity of the skeleton is a key factor in perpetuating osteoporosis, but this does not induce osteoporosis. The most proven therapy is adequate physical activity, and gradual decrease in activity with age triggers osteoporosis. Osteoporosis is reversible in early setting. Drug-induced or disease-induced osteoporosis is a separate story altogether, and setting in of a low-grade inflammatory process should also be considered in the therapy, and that probably is the next area of research, whether there is a true inflammation inside or not. But so far, we know that there is something called osteoimmunity, immunoporosis, which can be taken care of by simple daily exercise, by your activity. Whatever you do, it must be targeted towards your bone immunity, which improves the angiogenesis around the bone and definitely takes care of the future. So need some manual work every day to keep our bones strong. Thank you.
Thank you, Dr. Shobha, ma'am. It was such a nice, lovely talk.
Thank you.
Thank you, Shobha ma'am. That was very collaborative. I know you have a huge work on osteoporosis and bones. So this was a small drop from the ocean of your knowledge, but still thank you for enlightening us. The questions will be dealt later at the end of the session. So we'll be moving, with the permission of Dr. Aarti, we'll be moving on the next talk. Yeah. So our next speaker, I'm really happy to introduce two speakers from my place. Shobha Arora ma'am, also from Nagpur, and other second speaker is basically from Nagpur, Dr.Sonali pande ma'am. She is currently an orthopedic surgeon in sports medicine. She's based in Australia, and she is a member of APOFFS, Asia Pacific Osteoporosis and Fragility Fracture Society. She's a council member and lead at Fracture Alliance Services. So she'll be talking today on impact and burden of osteoporotic fractures. So over to you, Sonali ma'am.
Thank you, Neha. I'll share my screen.
Sure.
Can you guys see my screen?
Yes, we can see your screen, ma'am. Yes.
So I bring greetings to all of you for International Women's Day from Top End, Australia. I'm practicing in Darwin currently. At the outset, I would like to thank WOICE and especially Aarti for involving me in this webinar and giving me opportunity to talk on impact and burden of osteoporotic fractures. One in 3 women and 1 in 5 men have lifetime risk of sustaining osteoporotic fracture beyond the age of 50 years. These are very common in spine, hip, and wrist region. And these are being called as low energy, as in the force equivalent to a fall from standing height. As you can see from this publication, this is our almost 10 years apart. There is increasing trend of fractures, both men and women, with increasing age of sustaining the osteoporotic fracture. This is a widely used diagram we know from study by Cooper that the projected number of osteoporotic hip fractures are going to exponentially increase in Asia by 2050. There is added burden of increasing population of elderly. As you can see, there's trending, yellow is the current trending, and we are seeing by 2050, there's going to be rise in elderly population. And from the graph on right, you can see that most of these population will have increasing dependency on others for their day-to-day life. With increasing age, elderly will have morbidity, increasing dependency. And if they sustain any osteoporotic fracture, you can see these spikes will increase quite multifold their in general morbidity and dependency on others. We know that osteoporosis is a silent disease. Osteoporotic fractures can be compared as neglected disease. As you can see, the annual incidence of osteoporotic fractures are quite high as compared to other commonly concerned conditions like heart attack, stroke, and breast cancer. And they're even considered maybe higher than combined of all of these. If we look at the impact of osteoporotic fractures, we know that after a year of hip fracture, almost 4 out of 10 will be unable to walk independently. 1/3 of the population will need some kind of dependency and nursing care. And 1 in 5, or you can say about 20%, will actually have mortality because of hip fracture complication. Vertebral fractures are the most common. They are almost 1/3 of these fractures are not brought to the clinical, 2/3 are not brought to the clinical attention. They can cause back pain, loss of height, deformity, significant reduction in the quality of life, and have negative impact on the activities of daily living. It's interesting to note that the alteration of the quality of life can sustain almost 19 years after the initial fracture in the vertebra. There's also significant functional decline after a simple wrist fracture as well. If we look at the mortality, we know that both men and women will have a decreasing survival as compared to general population after a hip fracture. This study from Sweden has shown that the fragility fracture related deaths were third in as the top criteria of death that occurred in the elderly population after other common conditions like ischemic heart disease and dementia. It's interesting to note that even non-hip and non-vertebral fractures will show increased risk of premature mortality, and it's about 2-fold. If we look at the burden of osteoporotic fractures, there is enough data from EU which suggests that more euros are spent on fragility fracture management and rehabilitation as compared to conditions like stroke and coronary heart disease. This data looks at the economic burden coming from the osteoporotic fractures when compared to other common conditions that elderly population face, like admissions for septicemia, congestive heart failure, etc. The economic burden was maximum with the osteoporotic fractures. This is another article about low bone mass and its related fracture and overall global burden. And it's interesting to note that it has risen almost 110% over last 30 years. This study looks at what happens on the economic burden for subsequent fractures of osteoporosis. And there is significantly higher healthcare cost, almost 2-fold when there is subsequent fractures. And this only highlights that we have to also focus on preventing subsequent fractures in these osteoporotic patients. We know from the research that there is risk of future fractures, which is increasing in all bones with increasing age after initial fracture. The relative risk of new fracture increases almost threefold after the first fracture. So from all of this, we understand that secondary fracture prevention is a very important strategy. If we can focus on a smaller group, those patients with prior fractures, we can actually control about 50% of the hip fracture by targeting smaller population. So in summary, we know that the osteoporotic fracture are a major problem of healthcare. They're causing increasing global burden. They're common in certain specific bones, and they are cause of morbidity and mortality. There is increased dependency on others for activities of daily living, and they also cause heavy economic impact. Subsequent fractures are giving higher cost in the management. Therefore, there is role for secondary fracture prevention. I leave you all with this slide about prescription specifically for exercises in osteoporotic patients. It's important for us to be involved in their care to make them strong, steady, and straight. Thank you for your attention.
Dr. Sonali, sticking to the time, it's very important. Dr. Neha.
Yeah, thank you very much, Sonali ma'am. So that was very fluent and elaborative lecture about osteoporosis. So moving on to our next lecture, we all know that teamwork makes a dream work. So dealing with a subject like osteoporosis, we as orthopedic surgeon also need other specialties, and we have an eminent endocrinologist today, Dr. Usha Shriram ma'am. She is a president of ISBMR, which is Indian Society of Bone and Minerals Research Society. So over to you, Usha ma'am.
Thank you. So you can hear me, right?
Yes, we can hear you, ma'am, very well.
Okay. So thank you so much. And first, I have to tell you what an honor it is to be part of this absolutely great program, and to be with this such eminent group of women orthopedic surgeons. I personally have an NGO called Divas, which is all about diabetes in women. And so I'm just saying, I know the strength and the value of women empowered groups and women empowering women. So thank you so much. I'm just sharing my slides. Start with the first one. I hope you can see it. It's not the first one. You can see it now, right?
Yes, ma'am.
Thank you so much again, Dr. Aarti, for this very kind invitation. Just in the next few minutes, wanted to just share a little snapshot of what's going on in osteoporosis. So the definition of osteoporosis remains the same. So I just wanted to add that there is a trend towards thinking about maybe we should look at a -2 ST, especially based upon the NORA data and others that more people fracture at T-scores of below -2 rather than we call -2.5. So maybe we should be considering -2 as the point for starting, especially pharmacotherapy. So that's one point I wanted to make. As far as when we should be doing DEXA scans and evaluating women in our country, I think instead of sticking to the North guidelines of 65 for women and 70 for men, we are recommending that we go with 55 for women and 60 for men, and 55 or 5 years post menopause, whichever comes first. That seems to be the greater risk for women in our country. And of course, if women have unique risk factors or risk factors, for example, like diabetes, which increases the risk of fractures, you definitely want to screen and treat them at a younger age, and also want to add that probably their T-score needs to be adjusted by about half an SE. As far as evaluating, women for osteoporosis, women and men for osteoporosis, it's still good history and physical, basic laboratory examination, imaging that includes DEXA, and definitely spine film, because we don't want to miss an incident vertebral fracture. But here I want to add one of the new tools we now have is trabecular bone score, which is definitely added, to the strength of the DEXA scan, and the FRAC score, which is a no cost, 10-year risk assessment, both at the hip and at the spine. And we are using that a lot also. When it comes to evaluating patients with osteoporosis, we're still going with the dual energy absorption method. Though some tools for assessing quality, bone quality, which we now know bone quality and the bone mass makes the bone strength, and both are important. We are looking at other tools as well, but in clinical practice, it's still the DEXA scan, it's still FRACs, and in all of them who have been diagnosed with osteoporosis or a non-vertebral fracture, we should still do a spine film or a VFA to assess whether there is an incident vertebral fracture. As far as bone markers, we're not using them really for diagnosis, except maybe in patients with CKD, where we want to study metabolic bone disease versus true blue osteoporosis. And invasive techniques like bone biopsy, again, are reserved for very few instances, like this example of metabolic bone disease. Just a word about TBS score. Accurate bone mineral density scans and reports are crucial for obviously appropriate diagnosis. We can use TBS score to adjust FRACs. Low TBS increases FRACs estimated risk. High TBS reduces FRACs estimated risk. We want to use that. I already mentioned about diabetes. And when do we call someone as very high risk versus high risk? Because this is the new way of segmenting people with osteoporosis. If high risk is any score between -1 and -2.5, a history of a fragility fracture of the hip or spine, a T-score between the same range -1 to -2.5, and a FRAC's 10-year probability of major osteoporotic fracture of greater than 20%. The very high risk are prior fractures, patients with low bone mass who are elderly, frail, increased risk of fall due to other comorbidities, have very low T-scores, let's say more than -3.5, and taking glucocorticoids. So based upon this, I'll show you a slide at the end. We may segment them on what treatment that they will get. The treatment strategy is pretty much, it's calcium, vitamin D, as already mentioned, weight-bearing exercises, good nutrition. By the way, new data emerging that sleep is also important for bone health, good sleep, besides and avoiding medications like too much thyroxine, steroids, and besides all of those things, or proton pump inhibitors. We really right now are using only 3 medications, because 2 are not available. The oral bisphosphonates, we pretty much don't use. We've moved on to the IV bisphosphonates, largely for compliance, more than anything. And of course, it's very effective. Using either yearly IV zoledronic acid can be used for many years, but typically using it for about 5 years, followed by a drug holiday of 2 to 5 years. And if necessary, we are using sequentially with anabolics and then going back to some other form of anti-resorptive if necessary. The other anti-resorptive that we are using is denosumab, which we know can be used even in CKD, can be given sub-Q every 6 months. The only thing that we have learned, especially during COVID, when people discontinued their treatment, is a rebound, especially vertebral fractures that happen. So we really have to be very sure that our patients continue the medications, because it will have to be followed with another anti-resorptive or romosozumab. The anabolic that is available now that is teriparatide, we are using it for a year and a half to 2 years, actually 2 years, and monitored for high calciums and hyperuricemia during treatment, and absolute contraindications are, of course, bone malignancies and Paget's disease. Very, very important to ensure compliance with all these treatments, especially things that the patients have to do themselves. We look forward to agents like abaloparatide, which is the other anabolic that is available and being used in other countries, and romosozumab. Looking forward to the availability of these drugs. Of course, romosozumab seems to have increased risk of some cardiovascular events, so that is a flag we have there. We have gone on to this sequential therapy now in osteoporosis, where we might consider anabolic followed by anti-resorptive or anti-resorptive, and if that has to be stopped, or if there is suppression of bone for too long, we might consider an anabolic agent. I won't go into the mechanisms, but just to say that in very interesting pathways, especially the pathways involving Wnt signaling or the rank ligand, these are the areas that the new agents have been developed, and they have come a long way, and we're able to use very, very new agents. I'll end with this slide showing, this is also from Dr. Canis, who says, if you are very low risk, optimize calcium, vitamin D, risk appropriate exercise, and then reassurance, lifestyle advice. And for a select few, you could consider menopausal hormone therapy, especially if the women are younger, or they're taking them up to the natural age for menopause, or very early in the years post-menopausal and symptomatic, and selective estrogen receptor modulators. Of course, if they are high risk, we definitely have to consider, they've said oral bisphosphonate or some other inhibitor of bone resorption. And then, of course, very high risk, we can consider an anabolic or anabolic followed by an anti-resorptive. But what I want to mention here is the service called as FLS, or Fracture Liaison Service, that we now have in India in 2 places, in Chandigarh and in Mumbai, and planning to launch in other cities, which is really going to help identify patients who have the fracture and follow them up, because and educate them, and especially on fall prevention, because that seems to be the area where, as they say, the ball gets dropped. And we are definitely going to do something about that. Thank you so much.
Thank you, Dr. Usha.
Quickly, I would like to introduce our next speaker, Dr. Professor Emel Gonen from Turkey. And she is a member of Turkish Society of Orthopedics Traumatology, the European Federation of National Association of Orthopedics and Traumatology. And proudly, she is the founding member of Female Orthopedic Study Group in Turkish Society of Orthopedics and Traumatology. Over to you, ma'am.
Hi, nice to see you all here. I wish you a happy Women's Day, and it's my honor to be with you, such a talented, incredible woman here to meet you. I will mention about the role of vitamin D. So my screen is available to you, right?
Yes, ma'am.
Okay. Sometimes I have a problem in my camera, but voice will be available. So I will mention about the role of vitamin D in the bone. It's critically important for the maintenance of calcium and bone metabolism throughout life. It has many functions not on bone, but muscle performance, balance, risk of falling, and decreasing the risk of falling, increasing bone mineral density, and preventing fractures are the essential maintenance. And it works as a modular of up to 200 genes in cell growth. And the metabolism of vitamin D, when we look at the metabolism, the major function is maintaining serum calcium within the physiologic range, and within the osteoblast, we see here the vitamin D interacts with vitamin D receptor, and it increases the plasma membrane expression of rankle, and rankle on the pre-osteoclast binds to rankle on the osteoblast, and then this conversion of the osteoclast to the osteoclast make the serum calcium increase. So an individual vitamin D status is assessed by measurement of serum 25 hydroxyvitamin D, not the 125 dihydroxyvitamin D. And unfortunately, across skeletal muscle studies, there's not the cut point varies significantly, and there's lack of agreement on this. Although deficiency is generally accepted as less than 25 nanomole liter, and insufficiency is described as less than 50 nanomole per liter. And doses higher than 150 nanomole per liter is toxic. When we look at the role of vitamin D on fracture prevention, there is a significant reduction in hip fractures and vertebral and osteoporotic fractures when we use calcium and vitamin D or only vitamin D. We see some literature says that they see 33% lower rate for fracture and 22% lower rate for first fracture at any site compared to placebo with vitamin D. And doses between 500 to 700 reduces the hip fractures up to 20%. And also vitamin D alone or in combination with calcium have clear significant effects on bone mineral density. Serum concentrations of vitamin D were positively related to bone density of the lumbar, neck, and trochanteric regions of the femur. And this positive effect of bone mineral density may be even greater in 90 and 100 nanomole per liter in serum range of vitamin D. And doses more than 400 international units are associated with significant effects on bone health. However, the optimal dosage of vitamin D associated with these benefits remains unclear. And when we look at the muscle strength, vitamin D's deficiency and insufficiency are associated with muscle atrophy, deficits in muscle strength, and increased predisposition for falling. And how it happens? Vitamin D receptors is expressed in both skeletal muscle and myoblast cells. And vitamin D can increase protein synthesis and cellular growth in these muscle cells. So plasma vitamin D concentrations in the range of 40 to 90 nanomole per liter is seen to be associated with improved musculoskeletal function. The deficiency of vitamin D especially affects the proximal muscles, so the older adults could more quickly stand up from a sitting position when their 25 hydroxyvitamin D levels were above 30 nanogram milliliter. And vitamin D promotes skeletal muscle regeneration and mitochondrial health according to this cascade presented here. And when we look at the falls, vitamin D is shown to reduce the risk of falling up to 22%. And if we use less than 700, 100 international units per day, this effect is not seen, is not observed. So the vitamin D supplementation exerts greater effects on institutionalized versus free living individuals. And vitamin D can regulate cytokine production. And the cytokines interleukin-1, 6, and TNF-alpha regulate bone. And this cytokine stimulates osteoclastogenesis and subsequent bone resorption, osteoporosis. So those are, for example, interleukin effect is not, it is not, there are inconsistent results on this. They say sometimes in some literature results in bone formation, in some literature bone loss, but TNF-alpha and interleukin-1 is related with stimulation of osteoclastic activity. And as you see here, there are many immunoregulatory effects of vitamin D, and it significantly decreases interleukin-6 and TNF-alpha in vitro studies and in vivo studies, TNF-alpha. So what do we recommend? At least 1,000 international unit of vitamin D per day for adults aged 50 years and older should be used. And as a safe upper limit, we may say 4,000 or international units or up to 5,000 international unit vitamin D is suggested by the National Academy of Medicine. And what about pregnancy? This is my studies. There are two studies that says that pregnancy increases bone mineral density, but lactation decreases it. And the pregnancy and lactation both affects the dentin of the rats. But what do we use for women, for pregnant women? Do they need any excess vitamin D? Yes, they need up to 4,000 international unit vitamin D per day. And what is the treatment for maintenance? We don't recommend single larger annual bolus, but if 5,000 vitamin D daily for 8 to 12 weeks to achieve at least more than 30 nanogram per milliliter is required if there is an insufficiency or deficiency. And there is an alternative way to treat it, that is 50,000 international unit of vitamin D2 once a week for 8 weeks to fill tanks, then followed by 50,000 international unit vitamin D twice a month. And then maintenance is provided by 1,000 to 2,000 international unit vitamin D3 daily. So as a result, vitamin D has great role in bone health and fracture risk, and it increases bone mineral density, prevents fracture, and has very important role in muscle repair and remodeling, muscle function and balance, and decreasing the risk of falling. However, we should keep in mind that sports and muscle research has suffered from limited inclusion of female subjects. So on the day of Women's Day, on this day, we should imply that there are much more studies on females and much more animal studies on female rodents, since the vitamin D metabolism is affected by sex. So thank you very much. And this is, we're celebrating the Republic, our Republic, Turkish Republic. We are at the 100 years ago, we win the Republic like this by this strong, intelligent, and talented woman. So I wish you happy Women's Day all.
Thank you, Dr. Emal. Dr. Samu?
Yes, ma'am. Dr. Emel has given us a brief use of role of vitamin D in bone health as well as its role in preventing osteoporosis. It was a wonderful talk, Dr. Emel. Quickly, I would next like to introduce Dr. Pushpa Sethi, ma'am. And she has rich experience in obstetrics and gynecology over 46 years. And she has served as president of Gurgaon Obsgynae Society and president of IMA of Gurgaon, and also the president of Indian Menopausal Society. Quickly, I would like to hand over to Dr. Pushpa, ma'am, to enlighten us about the drug holidays in osteoporosis. Over to you, ma'am.
Thank you so much for the kind introduction. I'll just share my screen. How do I make it full screen?
I think.
Or is it okay?
A slideshow.
Just on your right.
Pardon?
Slideshow.
Yeah.
Yes. Yeah. So a very good evening to all of you. And as a gynecologist, whenever we are asked to talk in a on the subject of osteoporosis, and when there are orthopedicians around, we really get nervous because this never used to be a field actually. But from the time the Menopause Society started emphasizing so much the importance of good health in the menopausal years, osteoporosis became very important for us because that is one major thing that really hampers quality of life of a person, of a lady when she enters into the menopausal years, and how to prevent it, what are the importance of the lifestyle changes, all that has become an area of great interest for the gynecologist, and so also the pharmacotherapy. So osteoporosis, we have talked about the definition so many times, but it is basically loss. It's characterized by low bone mass, microarchitectural disruptions, skeletal fragility, and this results in decreased bone strength and an increased risk of fracture. The pathophysiology of osteoporosis results from an imbalance in the bone remodeling cycle governed by the osteoclast cells that break the bone down and the osteoblast cells that rebuild it. So this will be an important point when we talk of the drug-free holiday. Now, how do you preserve the bone mass throughout the lifespan? Number one is lifestyle changes. And we have talked in so many previous talks about the exercises and the importance it has, the important role it plays in strengthening the bone, and why the women of our older generation had strong bones because they did so much of physical activity, and the generation now has a lot of sedentary lifestyle. And the working is such that the lifestyle is extremely sedentary. There's no place for exercise. Even if there is, you exercise for 1 hour in a day, but the whole day you're sitting. So that has a bad effect upon your bone health. And number two is medication. So when we talk of drug-free holiday, we have to talk about the bisphosphonates. Now, bisphosphonates are non-hormonal, FDA approved. They inhibit digestion of bone by encouraging osteoclasts to undergo apoptosis or cell death, thus slowing the bone loss. And we have oral and the IV, as we have already talked about recently. Oral, we have alendronate, you have risedronate, abandronate, atidronate, and the IV, the most commonly popularly used now is the zoledronate. Now, coming to the osteoporosis drug therapy as such, the oral bisphosphonates are considered first-line therapy for the treatment of osteoporosis. Alendronate and risedronate are the most commonly used when we're using oral bisphosphonates, and with robust evidence demonstrating their benefits on vertebral and non-vertebral fracture prevention in women and men with primary or glucocorticoid-induced osteoporosis. Now, the major second-line therapies for osteoporosis include denosumab, intravenous bisphosphonates like zoledronate, and the anabolic therapies. Bisphosphonates have a strong affinity for the bone mineral hydroxyapatite and bind via the calcium chelating properties positioning them directly near the osteoclast because that is their target of action. So they are closely associated with the osteoclastic activity. As the bisphosphonates bind strongly to bone minerals, they can accumulate and endure for years. Now, this is very important when we think of a drug-free holiday. And in bone and circulation after therapy is discontinued. So they still remain for a long time in the bones after you discontinue the therapy. Extensions of RCTs have shown that for many patients, the risk of most type of fracture does not increase even after the discontinuation of long-term alendronate therapy. Most guidelines advise that patients at a low to moderate risk of fracture undergo a 2 to 3 year drug holiday from bisphosphonates treatment after 3 to 5 years of therapy. So this is one line where you give a treatment for 3 to 5 years and the patient gets a drug-free holiday of 2 years or 3 years as the, depending upon her symptoms and when she requires the second treatment. So the drug holidays reduce the medication burden, particularly for older patients. So this is important, and also the economic burden. When you talk of the drug burden, it also associates with the economic burden. Patients at high risk, high fracture risk, are recommended to continue the bisphosphonate therapy or switch to another osteoporosis therapy. Drug holidays are discouraged with non-bisphosphonate osteoporosis treatments, particularly denosumab, due to short-lived anti-fracture effects after the discontinuation. Very rare but serious effects. Now, what are the other important points when we are thinking of drug-free holiday? Very rare but serious adverse effects have been linked to prolonged bisphosphonate use. Osteonecrosis of the jaw has mainly been documented after high bisphosphonate dosages and when used for a long period of time. Rates of atypical femur fracture increase after 3 to 5 years of bisphosphonate therapy. Thus, the rationale for a drug holiday is to harness the residual bisphosphonate anti-fracture effects while stopping continued accumulation of the drug and potentially reducing the adverse events. Although initiating a drug holiday following the bisphosphonate therapy among the patients at low to moderate fracture risk is generally accepted, many questions still remain regarding the optimal duration. We really do not have enough studies to say exactly what is the ideal period of the drug holiday one should give once you stop the treatment after 3 to 5 years. The fracture intervention trial long-term extension, that is the FLEX trial, examined the anti-fracture benefits of continuing the alendronate treatment for 10 years compared to those stopping the treatment after 5 years. So the maximum time limit where it has been tried is around 10 years. So in high-risk patients with the greater risk of fracture, or in the patients where you want to use it for a longer time, we have studies up to 10 years of safe usage. But in low-risk patients or moderate-risk patients where you want to give a drug-free interval, or elderly patients or patients where you want to reduce the economic burden, you can give a drug-free holiday after 3 to 5 years of use, and the holiday can be 2 years, 3 years, or 5 years as you deem important or according to the patient's need. So to conclude, oral bisphosphonates have led to decrease in osteoporotic fractures globally. Strong evidence supports drug holidays for most patients after 3 to 5 years of continuous bisphosphonate therapy. Yet there is a lack of evidence about the length of the drug holiday to be given. The appropriate duration of a drug holiday is likely affected by the initial length and concentration of the therapy, drug retention pharmacology, BMD and the fall risk, and the patient's characteristics like the skeletal size. Future research is needed to examine the fracture risk by drug holiday length that considers how these factors modify fracture risk to form patient and therapy-specific drug holiday timeframes. Thank you so much.
Thank you, Dr. Pushpa, for giving us so much a good lecture. Thank you so much. Dr. Samu, the next speaker.
It's my pleasure to introduce Dr. Pooja Paul. She is an otorhinolaryngology specialist, and she also serves as a council member of the Otolaryngology Society of Sri Guru Ramadas Institute of Medical Sciences and Research Center, Amritsar. Ma'am, we invite you to talk about thyroid and bone health. Over to you, ma'am.
Thank you, everyone. I hope I'm audible. At the outset, I'd like to thank the organizers of WOICE, especially Dr. Aarti, for giving me this opportunity to address all of y'all. And like Dr. Pushpa mentioned, it's literally like teaching to the choir about osteoporosis. And I've been given 4 minutes to do this job, which is next to impossible, but I'll try to do my best of giving a brief overview. So coming to the role of thyroid in bone health, now weak bones have often been attributed to a reduced levels of calcium and vitamin D, like we have always been taught. But a very important factor which we ignore and which we don't address often is the role of thyroid hormones in the bone health. And this is especially important, especially among Indian women, because this is a picture which we unfortunately often see. And Indian women, they often don't address this issue. They don't seek treatment for thyroid disorders for various reasons for many years. So hyperthyroidism is an important cause of secondary osteoporosis, and which is an extremely common condition in India, affecting almost 80% of Indian women. Even if you look at the fractures which are associated with osteoporosis, they are twice as more common in women as compared to men, which makes it an extremely important issue which has to be looked into. So if you look at hyperthyroidism and thyrotoxicosis, the first report was by von Recklinghausen back in 1891, and this patient eventually succumbed to his disease. One of the commonest causes of hyperthyroidism is Graves' disease. And what happens is there's an excess of thyroid hormones which affects the metabolic systems of the entire body, affecting the CVS, CNS, and other systems, including the skeletal system. And there's a direct catabolic effect on bone mineral homeostasis, which leads to an increased bone mineral resorption and a loss of calcium through the kidneys. Like I already mentioned, it is an important cause of osteoporosis. And there was a study which was done by Uday Kumar et al. In 2006. And among his study population of hyperthyroid patients, he found that there was an incidence of osteopenia in 32%. And the rate of osteoporosis was as high as 60%. So it is extremely common in patients of hyperthyroidism. But what was very important and which I think is really relevant is that there was a reversal of bone loss after initiation of treatment. So this is a reversible condition. This is one of the treatable conditions that we can use to help patients with osteoporosis. Another factor which complicates this issue is the concomitant presence of vitamin D deficiency. And Graves' disease can be associated with a vitamin D deficiency, which is again twice as more common in females as compared to males. This probably because of a reduced intestinal absorption of vitamin D due to steatorrhea as well as hepatic enzyme induction. Another entity which we need to be aware of is subclinical hyperthyroidism. Now, this is a condition in which the levels of T3 and T4 hormones are normal. However, the TSH levels are low. The incidence in women is around 15%. It's a subtler disease. The patient is often asymptomatic, doesn't have any symptoms, and it is diagnosed during a routine screening. So this attained attention a couple of years back because it was associated with a higher risk of atrial fibrillation, especially when the TSH levels fall to less than 0.1. It can be associated with reduced bone mineral density, as well as an increased risk of fractures, especially in cases of females, especially postmenopausal. And it was also seen that in women over the age of 65, the rate of hip fractures was thrice as more common, whereas there was a 4 times higher risk of vertebral fractures in patients if the TSH levels were low. So I think this is again another very important factor which we don't look into, and it is a treatable and a correctable condition, which will definitely help the women's bone health. Hypothyroidism is a condition which is completely different from hyperthyroidism in terms of all signs and symptoms, except when it comes to bone metabolism. There is a reduced osteoclastic and osteoblastic activity, which leads to an increase in bone density. But unfortunately, the quality of bone is poor. So that is why, like hypothyroidism is also associated with an increased risk of fractures. So ultimately, both hyper as well as hypothyroidism are detrimental to the bone health in general. So to conclude my very short talk, with the changing worldwide geographic occurrence of bone disorders, it is important to remember thyroid hormones and hyper as well as hypothyroidism as a secondary cause of osteoporosis. Reduced bone mineral density in thyrotoxicosis is reversible with treatment as soon as 1 year after initiation of anti-thyroid therapy. In Indian population, this problem has a synergistic effect with the deficiency of vitamin D, which aggravates the bone loss. And even in asymptomatic patients, if they are diagnosed to be hypothyroid or hyperthyroid, regular medications as well as periodic checking of thyroid hormone levels is essential to maintain bone health. Thank you.
Thank you, Dr. Pooja Pal. Sticking to the time.
I tried my best.
Yeah, thank you so much. So we can start a panel discussion, and if there's some IO officials, so they can address. And thank you, all of you, for giving so much time on this day, International Women's Day, and Holi, because it was a holiday and it was tough for like me to collect everybody, but still everybody tried, and thank you so much. So we can go for a panel discussion, Dr. Samu.
Yes, ma'am. We had a wonderful speakers from all over the globe with the introduction of various specialities, including gynecology and ENT, and we got wide knowledge of how we can better treat osteoporosis by understanding the importance of vitamin D and how early in a menopausal woman we can treat osteoporosis. Also, the role of thyroid and ENT. Quickly, we can have a panel discussion with our panel members. Request the esteemed panel members to take over.
Happy Women's Day to everybody. Dr. Shobha, can I ask you a question? That is there any specific kind of exercise that boosts the immunity of the T cells, or any generalized exercise would do that? Like, is it a cardio, muscle building, or maybe just walking or something like that? Dr. Shobha, ma'am?
Yeah. Actually, the role of T cell is related to angiogenesis. They have said that exercise gives rise to angiogenesis, new angiogenesis because of periosteal activity to which the muscles are attached. However, this angiogenesis is not same as hyperemia. Therefore, this angiogenesis indirectly causes increase in the T cell population, which is still a matter of research. Exercise, how it affects the bones, is still under research as far as the immunology of bone is concerned. But all in all, the T cell population definitely increases with exercise. That's a wonderful thing.
So I have a question for Dr. Usha, Dr. Emel, and maybe Dr. Pushpa. Each one of you could take this. So what would be the difference for choice of drugs in a perimenopausal woman and a postmenopausal woman? If regularly a woman had to take certain medicines like a vitamin D, calcium, then what would they be in either of the situations? So if each one of you could just give a quick guideline which can be used in daily practice by everyone, that would be nice.
I may suggest 1,000 international units of vitamin D and plus calcium 500 milligram, and that's for all adult women if the vitamin D levels are sufficient, which means above 50.
And any role of calcitriol, like we didn't discuss about it, so it was just specific. Yeah.
Sorry.
Hello, everybody. Am I audible?
Yes, you're audible, Dr.
Yeah,
Mehta.
I just have one question for the panelists, for the speakers. Actually, after the discussion, what has been made clear is that osteoporosis is one of the silent killers, I should say, as all of us are afraid of hypertension and diabetes, but especially when I'm dealing with elderly people, I think it is one of the silent killers in elderly people. So as Dr. Shriram ma'am told that the screening for osteoporosis, usually we don't do it in your usual practice, that is usual practice, because it's DEXA scan is not present everywhere and it is a problem. So as she said that it should be done in after 55 in females, and maybe with all the females who come with the fracture. But are there any some guidelines from your society, from Orthopedic Society of India, who recommend some some other criteria for screening all patients of without symptoms, all postmenopausal females, or some age group is there?
No, actually, there are no such guidelines. That's what I was trying to understand from y'all, that what do we do for the perimenopausal? Because how the bone strength is probably before attaining menopause would make a lot of difference post that. So that's what I wanted to know, that could we make the bone health much better before we just like trying to go towards osteoporosis before the onset of it? So we don't have as such any guidelines for screening. And like Emel mentioned, like the daily supplements which people take, usually that is one of the regimes people follow. Otherwise, the weekly into 8 and along with calcium is something what we routinely prescribe as orthopedicians. But yeah, nothing for screening as such.
May I
Can I take
interject here,
a-
ladies?
Yeah.
May I interject here, ladies?
Yes.
First and foremost, I welcome you all on behalf of the Indian Orthopedic Association. And the reason I'm interjecting here is because, unlike what probably is known to you, the theme this year by Dr. Atul Srivastva is Strong Bones, Stronger Nation. And we have a very, very strong committee led by Dr. S.S. Jha and Dr. S.S. Amarnath, who are working towards making these guidelines, exactly what you women are discussing. And it will be great if the WOICE actually joins hands. And we do have people, the seniors who are non-orthopedic surgeons here. We are taking inputs from Dr. Usha, Shriram, and many other people, in fact, including the Indian Menopause Society. So having said that, we are working towards it. And the point which I've been a party to this entire discussion. One is we need to concentrate on women building their peak bone mass, PBM, at a much younger age, which is what you need to women push it. 25, 30 is the age group where you get your calcium and D3 in, and not wait till 45, 50. Next, I strongly recommend not overuse or misuse of DEXA in the perimenopausal or premenopausal phase. We have innumerable number of women who can be getting low T scores and normal Z scores, but are initiated on treatment premenopausal, which I think is an overkill. The other thing which I'm now making a statement, which is purely based on conjecture and experience and less on validation, is that very rarely can you get hypervitaminosis D3 with oral therapy. I repeat, very rarely will you get hypervitaminosis D3 with oral therapy. Throughout COVID, I have used 60,000 IU twice a month as a maintenance dose, unlike pre and post COVID, where it is 60,000 IU once a month. Overseas, and the international faculty mentioned, their maintenance dose is 30,000 IU, which is 1,000 per day. In our country, we need a minimum of 2,000 IU per day as a maintenance dose. But even if we are using 60,000 twice a month, which is 4,000 IU per day, we very rarely will go beyond 100 nanomoles. Plus, hypervitaminosis is not toxicity in vitamin D. And our Indian women are generally weak and low in calcium and D3. Hence, I would strongly recommend that don't just look at 30 as the cutoff, look, as very rightly mentioned, as 50 as the cutoff, and work towards getting vitamin D up. I mean, I have the right to say this because I've celebrated my mother's 100th birthday yesterday. All right. And she's 100 plus and walking around. The only thing I've stuck to is giving her calcium and vitamin D3. She's way beyond the anti-osteoporotics that we've used, whether it was bisphosphonate, teriparatide, or the works, but she's only been on this. So just get your calcium D3 in place, and you women live longer than men. And I'm sure that you will outnumber us very soon. So it's great. Please keep it up. And I love the entire discussion. Thank you for having us here.
Thank you, sir.
Thank you, Ramchandra.
Aarti, may I take a second on answering that question on a simpler
sir.
way? DEXA is not recommended routinely. That's very clear, obviously. One simple investigation that we used to use in AIMS Rishikesh was that take a good quality digital X-ray pelvis. Flat bones are the ones to show you osteoporosis at the earliest. And even if there is no osteoporosis, how do you judge the bone quality? It's not the femoral head. It's the Gothic arch, which is the superolateral part of the acetabulum, which forms a Gothic arch. And we are all conversant. It's right from our PG days, we are able to look at the Gothic arch. The trabecular concentration per unit trabecular concentration in the Gothic arch is the one that gives the idea of osteoporosis or osteomalacia also beginning there. Don't look at the femoral head. Femoral head comes much, much later. So the Gothic arch, plain simple X-ray pelvis and look at both the Gothic arches. You have an impression of a normal Gothic arch, and the lessening of number of trabeculae in the Gothic arch is the one indicator whether you need a DEXA or not. That's what we have been following.
Thank you, Dr. Shobha, ma'am. So I think so we can.
Yeah.
Yeah, because yeah, sure.
Yeah, I would like to thank the organizers for having a great job done by organizing this webinar. And thank you for giving me this opportunity as a panelist. And rightly said by Dr. Ram sir, that all the questions of at least my questions were answered, and he summed up all the lecture in just one go. And thank you so much. The speakers were amazing, especially Shobha ma'am and Emel and everyone else. Thank you.
Thank you, Dr. Ravisha. So I think so because we are running short of time. Dr. Rujuta ma'am, she is there. Dr. Rujuta ma'am, thank you so much for joining us, and thank you all the speakers, panelists.
But I'm sure you all did a wonderful job.
Thank you, ma'am. That's your inspiration, Shobha ma'am's inspiration, Dr. Emel, Dr. Chasanal, Dr. Usha, Shriram, Dr. Pushpa, Dr. Ravisha, everybody. It's because of you we are here, ma'am. Thank you so much. Dr. Rushma ma'am is there, Dr. Shobha ma'am. And once again, happy Holi and happy Women's Day. And thank you, Dr. Ram Chaddha, IO officials. Dr. Atul is not there, Dr. Ram Chaddha, Dr. Anup, Dr. Naveen, Thakkar. Thank you, Ortho TV. And thank you all speakers. And once again, living healthier lives everywhere, every day is the key. Power, privilege, and priorities, they embrace equity in women's healthcare. So our health is very important, and it's never too late to focus on our well-being. Thank you so much for joining. And we'll again.
Thank you, Aarti.
Thank you.
Thank
you. Thank you, Aarti.
Thank you, everybody. I thoroughly enjoyed
Happy
it.
Holi and happy Women's Day, everyone.
Thank you, Dr.
Thank you.
Pooja,
Thank you all.
everyone.
Bye.
Bye.
Thank you, Dr. Ram. Thank you, Dr. Sonali, Dr. Chasanal, Dr. Neha, Dr. Ritwika,
Bye,
Dr. Saraswati, Dr. Emel, Dr. Chasanal. Bye. Dr. Samu, thank you so much. Thank you, Dr. Shriram. Thank you, Rishi.